Good afternoon, everybody. At the outset, I'd like to thank Nitin for giving me a wonderful introduction, as well as giving me the opportunity to speak. I had the same question that Shilpa asked everybody: do we really need a femtosecond laser? Are we just doing it because companies are pushing it, or there is a peer pressure? And that was what my question 3 years back. And once I shifted to femto, then I realized it's not so. It is a completely new, different way that you feel. The safety margin, I've been doing LASIK for 15 years, and just 3 years back, I shifted to femto. And all these years, I've been using microkeratome. I never felt as safe as I do it now with the femto. Having said that, I'll just go over what are the 2 steps of LASIK. One is creating a flap, the second is performing a laser. And flaps can be created either with a microkeratome, femtosecond laser, or now the flapless LASIK has come. I'm sure Rupal has her own theory. She's saying, why a flap? Smile is going to be the best. Maybe we have to agree with her too. So microkeratome, we already have gone through the complications that Shilpa has shown. What are the limitations of microkeratome LASIK? It's a meniscus flap. It's not a uniform flap. Flap thickness is unpredictable. Whatever you say, you cannot determine what is going to be the flap thickness at the end of the procedure. It can vary from 10 microns to 35 microns, and more often it becomes thicker. And the flap diameter cannot be varied depending upon the K. And also you have to be very careful if you have very steep corneas or very flat corneas, because if you have a steep cornea, you're going to end up with a buttonhole if you don't use a smaller ring. And if you're having a very flat cornea, the chances of free cap are very high. All these problems are not there with the femtosecond flap. The deep set eyes is again a problem. And I think the CB1, I think they're able to do it without a speculum. But in a femtosecond laser, it's much more reliable. And thinner corneas, you can go for higher refractive errors. So if you have a 500 cornea, you can treat up to -8 if you do a femtosecond laser with a flap of 100 microns. That cannot be done with a microkeratome. So this is how it looks. A meniscus flap, which is, you can see that it's thinner in the center and thicker in the periphery, whereas a planar flap, which is common with a femtosecond laser. So these are some of the complications already I think Shilpa has talked about. We don't see them in femtosecond laser, and we do come across such condition. The advantage is you can just abort the procedure and just repeat the procedure 2 days later at a different setting, at a different level of thickness. Whereas in a microkeratome, if you have a complication like a buttonhole or a flap decentration, as you can see, the flap decentration, incomplete flap, all those things, you can't recut. You can't do it immediately. You have to make the patient go away and call them again after 3 months, probably even do a surface procedure. That's the greatest advantage of femtosecond laser. You can just tell them you had a minor problem, and you come back tomorrow, I can recut. That advantage is not there in a microkeratome LASIK, and that is the importance of the safety that the surgeon gets. So these are the complications we have already showed you with the microkeratome LASIK. Again, a free cap is a problem. This is one of my patients. Again, I'm using a 90 micron depth Moria microkeratome. One eye I had completed. So the same parameters in the other eye. When I did the other eye, patient had a free cap. Fortunately, as I lifted the microkeratome, I noticed that only the stroma was seen, and immediately looked for it, and I found it in the microkeratome head itself. So I just tarcoed the flap just to make sure I don't put the epithelial side down. Went ahead with my ablation and put the flap back. Unfortunately, until today, I always mark my corneas before making a cut, whatever type of microkeratome or femtoflaps I'm using. So having tackled the flap, you know exactly which is the stromal side. That's the greatest advantage. And I just put it back. I have a 10-year follow-up on this patient. It's very important when you have lost a flap, we don't see the flap, just look for it in the microkeratome. And I didn't even put a stitch. I just put a bandage contact lens, waited for 5 minutes, and now with a 5-year follow-up, a 10-year follow-up, she's doing extremely well. She didn't even know the other eye she had a problem. So you can manage any complication. That's the advantage with cornea. It is very forgiving. But the safety that you get in a femtosecond, you don't get in a microkeratome. And particularly, all these VIP patients, they are more prone for problems. So I would definitely put my hands up for femtosecond laser. So what are the causes of flap problems in microkeratome? Loss of suction, electrical failure, blockage of the foot pedal, accidental release of vacuum, a defective blade. That is again one thing. Reusing the blades is a major problem. I never reuse the blades. I use one blade for one patient, and that's it. I throw it away. Physical obstruction to the passage of microkeratome. You have to be very careful, drape the eye very well, otherwise you're in trouble. An incorrect setting of the hinge size, but I think now newer microkeratomes are much more simpler to handle. So the main thing against microkeratome flaps are you have to be very knowledgeable about the keratometry and how to change your hinge size, your settings, your ring size. All those headaches are not there with femto. Femto, whatever may be the keratometry, whether the eye is very flat or very steep, it doesn't matter. You just determine the diameter, you determine the thickness, the side cut angle, that's it. You can fix it for the entire the group of patients the same way, it doesn't matter. The other problem is a higher IOP. Nowadays, the microkeratomes have started producing lower IOPs. Flap striae, more because the type of the flap that it forms, the chances of flap striae, epithelial ingrowth, flap-related complications are much more in a microkeratome than in a femto. It's much easier to lift. If you can lift a flap even after 10 years, microkeratome flap. But after 3 months, can you lift a femto flap? No. So if you put the flap back properly on the first day, you don't have to worry because you're not going to have epithelial ingrowth, you're not going to have flap striae. And if you see a flap striae on the first day, even in a femto flap, lift it immediately, make it all right, and it flap fits very well. The flap fits like something like a manhole effect because it is either 90 degrees or at an acute angle. The flap sits very nicely on the bed and it seldom shifts. So flaps are more planar. The diameter can be controlled. The centration is very good. You can again control the centration in some of the newer femtosecond lasers. If it is slightly off center, you can actually center it to the pupil. And most of the times, the time taken is about 6 to 10 seconds. It's done so quickly. So this is how a docking arm looks. So just basically what happens is you have a suction on which the cone is docked. As you can see here, this is the blue one is the eye, and you can see the cone is docked, and then the vacuum builds up, and once the cone comes into contact with the eye, there's a second vacuum automatically takes up, and you can once the vacuum comes on, then it gives you a pattern of how the ablation is going to be, and you can shift it according to your necessity, because you can either make it very central, or if you're going to do some other procedure, you can change it accordingly. So this is the greatest advantage to the surgeon as well as to the patient, that you can have an individualized flap creation. There are other advantages. It doesn't only do flap, you can do rings. You can do keratoplasty, you can do lamellar keratoplasty. There are so many other advantages. Now you can do presbyopic inlays. And so again, when you compare a femtosecond flap with a microkeratome flap, the complications rates are very, very low. And if they do come, then you don't, like I told you, you can recut even the next day. So it's definitely an advanced technology. It's a major improvement in LASIK surgery. And today, if I would put my hands up for LASIK. I had the same debate in which I was talking about a blade microkeratome 4 years back in a Tamil Nadu conference. And I asked the same question, do we need a femtosecond? Are we just feeding the companies? No. In this case, absolutely no. Whereas I would say in a femtocataract, yes, that is questionable. But maybe once I start using it, I might change my mind. But once I think Shilpa starts using her femtosecond laser, she will tell me, yes, I made a mistake. Because it has definitely, it's a revolutionized flap creation in LASIK. It's more precise. You are more predictable. The flap thickness, standard deviation is about 2 to 3 microns. If you want to cut 110, you're not going to cut 160, which could happen in a microkeratome, and you could be way off. You might be making the cornea very unsafe, probably leading on to post-LASIK ectasia, which will never happen in a femtosecond laser because the standard deviation is excellent. And this is the flap architecture. Lower IOPs, again, about 20, 30 microns. It doesn't go beyond 30 millimeters of mercury. Desired flap thickness, actual variations will be 3 to 8 microns. Uniform flap thickness, again, I told you about the manhole effect. That is probably the most important thing. It fits so well because it's acute angled. You can't lift it unless you go, after 3 months, it's difficult for the surgeon to lift it. So you cannot dislodge it just like that. I had my patient who went to the US 1 year after LASIK. She was talking to a friend who was just talking with an invitation card, waving it, and she just lifted the flap. Just microkeratome flap, which can be lifted with the edge of an invitation 1 year after LASIK. It is frightening. I wouldn't do it. If it's my daughter, I wouldn't do it. I would go for a femtosecond flap. So reduced risk of complications, that's what we are talking about. In addition to the resulting flap, the uniform thickness, the most important thing is you have adequate space, particularly if you're doing a large diopter of astigmatism, if you're doing hyperopes, and patients with large pupil where you want a larger zone, then you can adjust the flap. You can make it 8.8, you can make it 9. And last week I had a patient with such a large eye, and when I put a 9 millimeter, it looked very small. So you can actually adjust the flap overall diameter as much as you want. Epithelial ingrowth is way low because it has to actually grow into the crevice and then grow into the flap interface, by which time the healing takes place. So it's not easy to get an epithelial ingrowth in a patient who has undergone a femtosecond laser unless you have really screwed up the initial procedure. So these are some of the studies which shows the flap thickness variability between microkeratome flaps and femtosecond flaps was statistically significant, but which is only 0.004. I think I covered this. See, this is one of the patients who had a small complication. I just want to show you what we did in this patient. Okay. So this patient was very uncooperative. And he kept moving. You can see how many times I've applied suction. I've tried to, when I'm just putting the cone, he has a very strong eye movement, and he kept doing it about 6-7 times. So I told him, this is the last time, I'm not going to do it anymore. Unfortunately, with very minimal movement, I was able to dock and applanate. So you can see still there is a little bit movement. I still went ahead with this thing. I was able to center it quite well, and I started the laser. So as you can see, once the laser started applying, you can see that there is some bubble which is just going in front. That's actually what is called as a vertical breakthrough. Actually, it is not going into the stroma, but it's going sub-epithelial, sub-Bowman's. So this area, actually, that area that you can see is actually not cut. Fortunately for me, it was just involving very close to the hinge, so I went ahead with the ablation. I just lifted the flap. I had enough area for it to be ablated. I just went all round and completed the ablation. But if the same thing had happened in the center, obviously I could not have continued, and we just have to do a recut maybe 1 day later or 2 days later. So this, I'm not saying that the complications will never happen, it will happen, but they are more manageable, they are less risky to the eyes, and I mean, the comfort that you get with the femtosecond laser, you sleep well. What she was asking is, do you sleep well? Yes, I sleep very well because I know I have my femtosecond laser to fall back on. I had a patient who had a microkeratome, very recently, who had a microkeratome failure in the middle of the procedure. You know what I did? I took her to the femto and completed it. She didn't even know that she had something gone wrong. So, and it was smooth. I set it on 160, and exactly it came the same level. That is the greatest advantage. The flexibility, the versatility of the machine is the greatest advantage. This is again one of my incomplete peripheral cuts. See, if you can call it a complication, yes, it is one of the complications, because see, as I finished the laser, you see, I'm trying to lift the flap. It's not going any further because the peripheral cut is not complete. Probably at that area, a little bit of loss of suction. So I just used a Vanas and opened the flap and completed my procedure without any problems. So you can see this. Again, the most important thing is the first line, read the first line, strong peripheral wound repair. So that is a critical advantage of femtosecond laser. So you have a side cut which is at acute angle or at 90 degrees vertical. You have a strong peripheral wound repair. So the post-operative late onset complications are much less. And the other thing is, it is the separation with air is it's easier on the eye. So chances of post-LASIK ectasia developing is much less because biomechanically the eye is stronger. You just imagine the collagen fibrils are like bands of elastic rubber bands, and you cut them, what happens? It sags. So that's what happens in a microkeratome LASIK. So they say even if you have not ablated, that's why even in 1.25 you can develop ectasia, if you correct 1.25, because when you cut the eye, there is the sagging of the corneal collagen fibrils actually starts the process of ectasia. Whereas in a femtosecond, there's a neat separation. So you just, bundles of hair are stacked on one on top of each other, and then you just separate them with air. The chances of biomechanical instability developing or the strength of the cornea going down is much less in a femtosecond flap.
Sujatha, can we sum up? Because
yeah, sure. So the other things, you can use it for so many other advantages. So I'm just finishing out. So there are other studies which have compared femtosecond laser with all of them in favor of femtosecond laser. So you have to accept that's a major advancement in LASIK. It's got predictable outcome, excellent safety and precision, faster visual recovery, patient safety and patient comfort, enhanced quality of vision. But in conclusion, I'd like to say tools are only as good as the surgeon using them. Perfect results can be achieved by striving for perfection, immaterial of what type of machine that we are using. Like Shilpa said, old is gold, but new is diamond. So I'm going for diamond shopping. Thank you.
Thank you, Sujatha.
Thank you.